Good afternoon, everyone. Welcome. My name is Ankit Mehta. I'm a nephrologist, and with me I have Dr. Stacy Kalish. She's a geneticist, and we're together going to talk about Fabry disease. So thank you for coming to our seminar this afternoon. This is the agenda. We just talked about this, and we have two learning objectives. We'll talk about the pathophysiology and appropriate evaluation of a patient with Fabry disease. And then we'll talk about recognized current and some investigational therapies that are coming down the pipeline for Fabry disease. We need a couple of housekeeping items. If you haven't downloaded the NKF app, please go ahead and do that. Both me and Dr. Kalish have agreed to share our presentation on the app, so it should be available for you in PDF version. And we want to thank our sponsors, Amicus and Chiesi, for helping putting together this event. So with that, I'm going to hand it over to Dr. Kalish to start the first part.
Great, thank you. Okay, so as you heard, I'm a clinical geneticist. So I am split my time between Penn Medicine and the Children's Hospital of Philadelphia, in Philadelphia, and at Penn I see a fair number of patients with lysosomal storage diseases, including having a pretty big clinic with Fabry disease. These are my disclosures, the most important of which is I am not a nephrologist, so outside of the Fabry-related and genetic disease, the rest of this is a little outside of my realm. So as you heard, we're going to, these are our objectives, and I'm going to handle the first part. So we'll talk about the pathophysiology and evaluation and clinical features of patients with Fabry disease, and then I will turn it over to Dr. Mehta to talk about current and investigative therapies. Okay, ooh, that went fast. So, okay, a quick question. If you're in the app where you can just show of hands, this is the only one we have, but how many of you are currently managing or have managed patients with Fabry disease? Quite a few, I like that. How many of you have seen patients with Fabry disease overall? Okay. That was not a question I put up here, so that was a bonus, but I would be concerned as a geneticist if you have never seen a patient with Fabry disease, that we might be missing patients with Fabry disease. So we'll talk about that a little bit. Okay, so here's our agenda, and we have a lot to cover, so jumping in. So Fabry disease is a multi-system lysosomal storage disorder, and it's caused by a deficiency of alpha-galactosidase A. So hopefully you remember a little bit about lysosomal storage disorders from biochemistry. It leads to an accumulation of glycosphingolipids, specifically GL3 and its metabolites, in the endothelial cells. And so on the right side of the slide, you can see all of the many organ systems that are involved because of the storage in the endothelial cells of those organs. And we'll talk about the key organs in a little bit more detail as we go through. There are both classic and late onset forms of Fabry disease, and it's an excellent condition, though it's really important to recognize that females frequently are affected. We used to refer to them historically as carriers and think they were not affected, but we know this is completely not appropriate any longer. So when we talk about the epidemiology, again, my whole world is sort of rare disease. So as far as rare disease goes, this is relatively common. When we think about the classic Fabry disease, or the earlier onset form, estimates range from 1 in 50,000 to 1 in 117,000. We know, though, that the late onset or non-classic form is much more common, and also likely significantly underdiagnosed. So when we look at unbiased populations such as newborn screening studies from across the U.S., we see rates of Fabry disease overall somewhere between 1 in 2,200 to 1 in 9,000, so much, much more common. In Taiwan, there was also a newborn study screen, and there's a common cardiac variant there, so there the Fabry disease seems to be really quite common. And then from biobank studies in the UK, looking at specific variants in, again, an unbiased population, about 1 in 5 to 6,000 for late onset Fabry disease, and maybe about 1 in 200,000 for the early onset form. We can also look at populations in high risk, who have high risk conditions. So looking across populations of patients receiving dialysis, in this one study, 0.3% of males and 0.1% of females were found to have Fabry disease. Similarly, looking across populations with hypertrophic cardiomyopathy and premature stroke, the rates are quite significant. Okay, so thinking about the pathophysiology, as we've said, Fabry disease is caused by a deficiency of alpha-galactosidase, which leads to storage of GL3 and other glycosphingolipids. We'll talk specifically about lyso-GL3, which is one we can measure a little bit later. And this occurs across many cell and tissue types. Consequences of this include poor perfusion because of storage in the vascular endothelium. We also see direct damage to cells from these GL3 deposits. And so these together lead to cellular dysfunction. We see triggers of inflammation and fibrosis. And from there, we see progression of disease. And so we can begin with symptoms in sort of the lower of the, I don't know if this angle. Wow, look at that. Okay, so here, sort of thinking about neuropathic. Oh, I could do that.
Yeah.
Is that there? Oh, look at that. Okay, so here, thinking about symptoms that are early onset, and we'll talk about those in a little bit. With progression, we see early signs of cellular dysfunction and early signs of organ damage, and then this will progress without treatment. Okay, so we've talked about classic and non-classic disease. Classic disease is seen typically in males who are heterozygous, and we'll review a little bit of genetics in a few minutes, who have less than 1% of enzyme activity, though we can also see classic Fabry disease in females. Symptoms onset may be as early as 3 to 5 years of age in males, and can occur anywhere from childhood to adolescence. We actually see symptoms onset before we see organ damage in classic disease. So we see these characteristic angiokeratoma, and you can see these here around this belly button. And in this higher up picture, which is kind of a side flank view of an individual. So we talk about angiokeratoma occurring really in a bathing suit distribution, especially in males, so sort of in between the belly button to the upper thighs. We also can see episodic severe pain crises, mostly in the extremities. We used to refer to this as acroparesthesia, but more often just call it neuropathic pain now. This can be triggered in children with heat and fever, also can be triggered by stress in general or with illness. We can see hypohidrosis and complete anhidrosis, so this can further exacerbate heat intolerance. And then GI symptoms in children and adolescents with abdominal pain, early satiety, frequent diarrhea, difficulty gaining weight, and other symptoms. With time, again, this is a progressive condition, so we can see ongoing organ manifestations without treatment. So chronic kidney disease is one of the main features and why we're talking about it here at this meeting. So we see proteinuria beginning often from childhood or certainly by adolescence. Without treatment, we see a decline in the renal function. So we see decline in renal function in about half of males in their 20s and 30s, and in about 90% of males by their 50s. Again, this is progressive, and I'm not going to show you this data today, but there's some evidence that there is a point of no return. So a point at which if the kidney disease progresses, even treatment for Fabry disease will not protect the kidneys any further. Cardiac disease is also a major cause of morbidity and mortality and occurs in male patients by around their 50s. So we see left ventricular hypertrophy with progression to concentric cardiomyopathy and fibrosis. We can also see arrhythmias, and these are commonly bradycardic arrhythmias. We can see sinus bradycardia in young male patients to the 40s or even the 30s, and also can see increased rates of atrial fibrillation. And then we see white matter lesions in the brain and early onset of TIA and stroke. And without treatment, the mean age of death in males with classic disease is 41 years of age. When we talk about late onset or non-classic Fabry disease, the features can be limited to a single or a few organ systems, or can involve all of the things that we've just talked about. This also may present at later ages, even in male patients, than classic Fabry does. So we often see cardiac phenotypes that will present in the 50s to the 70s. We'll included this earlier before we can see manifestations elsewhere is by late gadolinium enhancement on a cardiac MRI. Renal failure is rare and certainly does not occur as frequently as it does in classic disease, but we do see glycosphingolipid deposition in podocytes and mild to moderate proteinuria. TIA and stroke risk is also an issue in non-classic disease. But the symptoms that we talked about initially that occur early in children in classic disease are less frequently present, which makes late onset Fabry disease harder to recognize. We often don't see GI symptoms, neuropathic pain, sweating abnormalities, which makes these things, kidney disease, cardiac disease that are common in the population, hard to recognize that this could be due to Fabry disease. And there are some genotype-phenotype correlations, and we'll talk about those in a minute. First, I want to just highlight Fabry disease in females. So as we've said, can really range from completely asymptomatic throughout life to being as significantly affected as males. Often females do have a milder course or have later onset compared to males with the same variants. And this is really due to patterns of X inactivation. So again, I know we're stretching a little bit to like your early medical education, but hopefully you remember a little bit about X inactivation. So most males, in cats, just like in humans, most males have one X chromosome and one Y chromosome, and most females have two X chromosomes. And the way we balance that extra X material is by random inactivation of one X. This happens very early in embryogenesis, and then is stable throughout descendants of those cells. So you can see here in the male cats on the left here, again, they have just one X chromosome, and the calico cat is really the classic example of this because of how well it's visually represented. So the gene that determines whether you have orange or black fur is on the X chromosome. You can see these male cats, they have one or the other, and they are either orange or black. Maybe some of them chose orange for, apparently that's kidney foundation colors today, so they've dressed appropriately. But when we look at the females, again, they have two X chromosomes. So if both of their X chromosomes have the black version of the gene, then the cats are black. If both have the orange version, then the cats are orange. But for cats who have one copy of each of these versions of the gene, this is a co-dominant trait, so you can see which cells are expressing the orange and which cells are expressing the black. We can't see this in humans the same way, but you can imagine in any organ in a female with Fabry disease, if the abnormal X is active in the organs of interest, so in the kidney or in the heart, we can see much more significant disease there. And if the normal X is active, then that's protective. And this is data from a study that I was involved with looking at 42 females, which is actually, this is the largest study of Fabry disease to date of clinical features in females. And this was fairly recently published, and these were females who participated in clinical trials for one of the available therapies. And so you can see in the table on the left which of their organ systems, looking at the 5 major organ systems, were involved. So you can see 5 or 12% of this population had involvement of all 5 systems. In this study, all of the females had at least 2 organ systems involved, and that was part of how they were in the trial. And then this image over here I really like. So each ring represents one of the people in this study. The darker their color is, they have more organs involved, and the lighter color is fewer. And then each of these shows which of their organs. So, for example, the 5 outer rings represent the 5 females where all of their organs are involved. And then the others show which of their organs are involved. I should also mention cornea verticillata, which you can see a picture of at the top right. This sort of spoken wheel pattern that we can see in the cornea is actually more common in female patients than in males, and is often what leads to a diagnosis for females or the first person in a family. Okay, so how do we make a diagnosis of Fabry disease? We can use alpha-galactosidase enzyme assay in males when we suspect Fabry disease, but it is not definitive in females. So a normal enzyme in a female patient does not rule out Fabry disease. And I like this picture on the right, which has really like a nice algorithm to walk through. So if you start at the top with suspicion, either based on clinical history or family history for Fabry disease, if your patient's male, you can order an enzyme test. If the enzyme test is normal, they don't have Fabry disease. If they do, you should go on and do genetic testing. And for females, we should start with genetic testing. One of the important pieces here is that if the patient has a known family history and a known variant in the GLA gene that's already been identified, then you can do targeted sequencing and look just for their known family variant. If that has not been identified or they're the first one being evaluated in the family, then we need full gene testing. You may be familiar, so molecular testing of the GLA gene can be ordered on its own, but you may be familiar with next generation sequencing panels. These panels look at anywhere from a handful to many hundreds of genes, depending on the phenotype of interest. So certainly there are renal next generation sequencing panels that include GLA. It's also included on panels related to cardiomyopathies, arrhythmias, neuropathies as well. When we find variants, if we're not certain about the phenotype or if we find uncertain variants, lyso-Gl3 is a biomarker that can be measured in the blood that can be useful for evaluation and determining severity of phenotype. We know it also correlates and decreases with therapy. Okay, and then this is the bulk of our genetics right here. So again, a reminder about X-linked inheritance. So most of the time, Fabry disease is inherited from an affected parent, although it can occur new in an individual or de novo. And so over here, you see these sort of classic pictures talking about what happens when a person with Fabry disease has children. So here, again, this male person who has Fabry disease has only one X chromosome. It's colored red here because it's not working. His other sex chromosome is a Y, and this is really what determines the sex of the children. So if he passes on his X chromosome, then he has female children, and they all have Fabry disease. If he passes on his Y chromosome, then he has male children, and they are not affected. On the other hand, if a female has Fabry disease, so she has two X chromosomes, you can see the normal one here is yellow, the red one is abnormal. She will pass on one of her X chromosomes to each of her children, so all of her children, regardless of sex, have a 50% chance of inheriting Fabry disease from her. There's a really useful tool that's available online. There's a site for it here that's fabryfamilytree.com. And either people or clinicians can build a family tree going through here. So you see one of the options is you are a person with Fabry disease. One is you have a family history. And you can build out, so we'll say who are your siblings, who are their children, who are your aunts and uncles, your parents, and we'll determine who is at risk and who is not at risk. This is important because cascade testing is really important in Fabry disease. We know from newborn screening studies, and the pedigree at the top here is from a study that came out of Portugal on a common variant there, that once a newborn is identified, or any person is identified really with Fabry disease, we find on average about a half a dozen people who also have Fabry disease. So you can see in this pedigree here, this is the newborn who had newborn screening with the arrow, his mother, and then a number of other maternal relatives were identified. And you can see some of these people have question marks, so this is even without full screening of the whole family. There's also a study that came out of a Danish cohort, so because of the small size of their country and their nationalized healthcare system, in this study they were able to complete cascade screening on every relative who was at risk related to their 18 index patients. And so they found 97 additional people with Fabry disease who were related to their 18 original patients. Importantly, there was a lower age of diagnosis in people who were diagnosed based on family history rather than their index patients, which just highlights the importance of medical genetics and genetic counseling, because earlier diagnosis can lead to earlier treatment and better outcomes. Okay, so one of the things we wanted to talk about was really genotype-phenotype relationships. So if you're not familiar with these words, this is really taking the specific genotype or the specific variant in the GLA gene and looking at what we know about the phenotypes that are correlated with that. So you can see in this graph, on this image on the right, there are some variants, and the ones in the green here are a little bit controversial. We're not going to talk about them, that may be risk factors or may cause really mild disease or may be benign. There are variants and then as we kind of go up, we see increasing severity with certain variants. This is helpful for people who have recurrent variants, but we know that many people and many families who have Fabry disease have private variants. And so then we really need to use the clinical features that are seen in male patients, sometimes those biomarkers to try to determine the severity. We also can see wide phenotypic variability even among people with the same variant. We know, though, that classic disease can be caused by missense or nonsense or splice site or gene rearrangement, so really any type of variant that leads to absent or very low amount of enzyme activity. Whereas late-onset disease is caused specifically by missense or nonsense variants that do lead to some residual enzyme activity. Amenability to migalastat, which is one of the approved therapies that Dr. Mehta will talk about more in a little bit, is also dependent on the specific GLA variant, so identifying the variant is helpful for patient care. I'm going to highlight just two common recurring variants because we know a lot of information about these. The most common recurrent variant in the US probably is this N215S. So we refer to variants based on their protein name. So remember just the amino acid that should be there, this position along the protein, and then the amino acid that is there. And N215S is fairly common in the US. So this data here comes from 125 patients who were part of an international registry. And it's really a primarily late onset cardiac variant. So we see mostly cardiac clinical events in these patients. We can see mild left ventricular hypertrophy beginning as early as the mid-20s to mid-30s in patients with this variant, and in females, but at a later age. Renal events and cerebrovascular events are certainly less common, but from the registry study, we know that renal impairment, and they define that as an EGFR less than 60, occurs in 17% of males with this variant, mostly from their mid-60s or later, and only 3% of females. So you can see that here in these bar graphs at the top, where the top one represents males, the lower one represents females, and then the blue bars are the patients with the N215S variant, and then the red bars are those without. So you can see that EGFRs are higher for all of the patients across all age ranges with N215S. And then in another study looking at onset of proteinuria, the median onset was 71 years versus 43 for people with other variants. And the median age where the EGFR dropped below 60 was 72 versus 56 for those with other variants. So you can see those here in these graphs, again, where the green is the decrease the percent who have EGFR below 60 for all other variants, and then the black is for the N215S. So of my practice, at the time I put these slides together, we had seen 108 unique patients. We're up to 109 now, but 14 of them have this specific variant from 8 different families. And there are a couple of other late onset, primarily cardiac phenotypes associated with these other variants listed up here. I wanted to highlight R112H as well because this is a variable late onset variant. It has been confirmed to have reduced alpha-Gal A enzyme activity and elevations in biomarkers in males. But the suggestion is that this is likely a late onset renal variant. So we can see progressive renal disease in patients with this variant, and biopsies do show characteristic GL3 storage. Cardiac biopsies do not seem to show storage, although there are some reports of males who do have LV, and there are some reports of males who don't have significant cardiac disease later on in life. And in my clinic, we have 8 of the 108 patients have this variant from 5 families. So just to wrap up, I'm going to talk a little bit about how we manage and monitor patients with Fabry disease. Monitoring patients is really multidisciplinary and it occurs across many different organ systems. We're not going to go into this in a lot of detail, but certainly we recommend frequent general evaluation with people who have experience with Fabry disease, and then frequent renal, cardiac, cerebrovascular monitoring, and then we monitor other body systems as needed for individual patients. These guidelines are almost 10 years old now, so there may be some newer ones coming in the future. And then I really just want to touch on how we think about approaches to Fabry-specific therapy and really lysosomal storage disease therapy in general. So this really just reviews the general ideas for how we approach managing these diseases. There are currently 2 types of approved therapies in the US for Fabry disease. One type is enzyme replacement therapy, and so I like this image because it kind of shows what all of this does. This is actually delivering a version of the abnormal enzyme so that it can go to the lysosome and break down GL3 and do what the abnormal enzyme is not doing. The other approved therapy is over here is a chaperone therapy, and chaperone therapy, as I alluded to earlier, is really mutation or variant specific. We know that some variants in GLA have a little bit of residual enzyme, but they typically get picked up by the cell as abnormal and recycled before they can go to the lysosome and function. And so what the chaperone does is it interacts with that abnormal protein, literally kind of like walks it over to the lysosome, so it targets it to the lysosome, and then it releases and lets it do its job there. Other therapies that are currently in clinical trials include substrate reduction therapies. So these are small molecule therapies that instead of reducing storage, help you actually make less of the material that is stored. So in this case, making less GL3 so that there's less storage in cells. And then there's a couple of approaches to gene therapy, which are in clinical trials as well. These involve either delivering machinery and a corrected copy of the gene to correct the genes within the affected individual directly, or taking stem cells from an individual, correcting them outside the body, and then returning them to the patient. I'm going to not talk about the approved therapies because Dr. Med is going to do that in a minute, but I do want to highlight that we typically recommend patients, for adult patients at least, we recommend therapy for all male patients, whether they have classic or late onset disease, because we know this is progressive and that they're at high risk for complications. We recommend treatment for females who have any signs or symptoms of disease or who have significant amounts of lyso-GL3 storage, because again, we know that they're at increased risk for complications of disease. I would recommend and offer therapy to any female patient who is interested in it, even if the biomarkers remain normal, because we can't predict the future. There's also adjunctive therapy, and I'm not going to go into this as well, is super important for patients as well. So in addition to Fabry-specific therapies, it's important that we manage, try to prevent complications like renal and cardiac disease, and also treat symptoms of neuropathic pain, GI symptoms, lymphedema when they occur. So for me to wrap up, just one, again, Fabry disease is a multi-system lysosomal storage disorder with classic and late onset forms. We see significant morbidity and impact on quality of life. It's an excellent condition, but both males and females are affected. Genetic counseling is very important. We don't want to miss this diagnosis because there are Fabry-specific therapies available. And it's really important to involve healthcare teams that are experienced with Fabry disease, and this can really lead for better long-term management and improved outcomes. And that is it. I'm going to come out of here. Let's see if I can get yours. Oh. I think you're on your way.
Thank you. Thank you, Dr. Kalish. Okay, I have a different question for the audience. How many of you guys have seen a patient with PKD? I want to see every hand go up. Have you seen a patient with PKD? If you've not, I'm going to pick on you. You've not seen a patient with PKD. What is the incidence of PKD in general population? What is the prevalence of PKD in the general population? 80 PKD. 1 in 1,000. Yes, that is exactly right. So there was a newborn screening. So the state of Missouri started newborn screening for Fabry disease about 10 years back. And they published their first 3 years of newborn screening data. And that had an incidence of 1 in 1,200. So what I'm trying to tell you is Fabry disease, on all its variants, not just classic Fabry, but late onset Fabry included, is almost as common as autosomal dominant polycystic kidney disease. So if you've not seen a patient, you probably missed a patient or two. Okay, one more point I want to make about what Dr. Kalish was talking about. Testing, and she mentioned GLA testing or enzyme testing would be the best way in men. Reality is it's a lot easier for an average nephrologist to be able to get genetic testing than to get enzyme testing done. So I flipped that over its head. I would do genetic testing first, and then if it's positive, figure out whether, check enzyme level afterwards. The problem is then you end up with tests that you don't know how to interpret, and then I have to call her.
And then you call your genetics friends for help.
Yes. So there are pros and cons for both approaches. Okay, so these are my disclosures. I'm going to do the second part of the presentation. We'll talk about current and investigative therapies for Fabry disease. We talked about the agenda. And Dr. Kalish already went over this, but when I'm thinking about therapies, I split them up in 3 different buckets. First is a classic patient. Classic patient has less than 1% or less than 5% alpha-gal enzyme. When you have very little or no alpha-gal, you need therapy very early in life. So the classic patients, all of them should be treated. The heterozygous females, you start looking for symptoms or evidence of organ involvement. If they have symptoms or evidence of CKD that is related to Fabry or myocardial scarring that's related to Fabry, they need treatment. Then there is this late onset and cardiac-only variants, so-called renal-only variants, so-called, and I'm putting them in quotation marks because we're moving away from calling them cardiac-only variants and renal variants because we see that there is some degree of involvement of other organ systems in these cardiac-only variants as well. But the late onset patients, you think of them again like the heterozygous females. If they have symptoms or if they have evidence of involvement of the key organs, you treat them. When you're looking at all the treatment for Fabry disease, I split them up into 2 buckets. On the left, you see Fabry-specific therapy, and on the right, I put them as supportive therapy. Fabry-specific therapy, there are only 3 in the US. There are 3 approved agents. The first one up here, enzyme replacement therapy, egalsidase alpha, Repligal, is not approved in the US. The other 2, Fabrazyme and Elfabrio, egalsidase beta is Fabrazyme, and pegunigalsidase alpha is Elfabrio. They're both approved in the US. And then migalastat, or Galafold, is a chaperone therapy. I am going to touch on the investigational therapies afterwards, and I have a little bit on supportive therapies if we have time towards the end. Okay, starting off with the egalsidase beta, Fabrazyme. The way I tell my patients what is Fabrazyme is you're basically getting replacement of the alpha-gal enzyme. So they're analogs of the alpha-gal enzyme that the patients are missing on, and they're infused intravenously. So the mechanism of action, it's an exogenous source of the alpha-gal. When infused, it binds to alpha-6 mannose receptors, which are the natural receptors on the cell surface, gets internalized and shuttled to lysosomes, where they start breaking down GL3. The dose is 1 milligram per kilogram every 2 weeks, and there are 2 big warnings that come with this infusion. 1, anaphylaxis, it's about a 1% risk of anaphylaxis. 2, allergic or hypersensitivity reactions, or some other infusion reactions. The infusion reaction risk is as high as 59% in the clinical trials, so it's significantly high. The second bucket of concerns is immunogenicity. So egalsidase beta antibodies develop in patients with getting these infusions, and there's concern that high titers of these antibodies, some of which can be neutralizing, might actually negate the effect of the infusion. There's not good data about it, but we monitor these antibody titers closely. The studies that got egalsidase beta approved, there are 2 major studies. This one's the first study, and it was called Study 1. Don't ask me why, but they called it Study 1. They don't come up with a better name. 58 naive patients that get randomized to egalsidase beta or placebo for 20 weeks, and then there's an open label extension for 54 months. And as you can see on the right, biopsies of the kidney, heart, and skin cell show a rapid drop in the GL3 levels in as early as 6 months. You can check GL3 in serum, and in the interventional arm, let me put my cursor there. In the interventional arm, on up there, in the interventional arm, you see a rapid drop in serum GL3, while the placebo arm's stable. And once they are in the open label extension, everybody's GL3 normalizes. The next study was called, guess what? Study 2. Study 2 had 82 naive patients that get randomized 2-to-1, 2 patients getting egalsidase beta to 1 placebo. And here the question was clinical. What happens to the risk of stroke, so cerebrovascular events? What happens to the risk of cardiac events? CKD progression, and death. And you see on the right side, there are less in the egasidase beta arm compared to the placebo. These two studies were pivotal to getting egasidase beta approved, I want to say somewhere around 25 years back? 2002. Yeah, the publication was 2001. So it's been out for a while. There have been other studies in kids, which I'm not going to go over, but it's approved from the age of 2 and up. The next drug I want to talk about is peg-unigalsidase alpha. Peg-unigalsidase alpha, brand name is Fabry. The difference between this is also an alpha-gal replacement. The difference is they took 2 molecules of alpha-gal and put them together with PEG. And when you do that, the circulating half-life goes up significantly because PEG is such a big molecule. And the thought was this longer half-life would be beneficial. So the mechanism of action is the same. You are replacing the alpha-gal. The warnings, the dose is the same, 1 milligram per kilogram every 2 weeks. The warnings are similar. There's hypersensitivity reaction and anaphylaxis. There's infusion-associated reaction. In the studies, there were about 30% infusion-associated reaction and 1 case of MPGN that happened in the clinical trials. Immunogenicity is also a concern, even though it's thought to be less immunogenic than egasidase beta. The studies that got it approved are, this one's called Trial 1, not Study 1. Trial 1 was an open-label dose-ranging study with 18 patients, and again, they were looking at clearance of GL3 in the kidney. They used a fancier way to quantify the clearance. It's called Bliss score. But the bottom line is you have GL3 clearance within 6 months on kidney biopsies. The next trial was called, Balance. Everybody fell for that. Balance study was interesting because Balance study was a head-to-head comparison of peg-unigalsidase alpha with egasidase beta. So they took patients that had been on egasidase beta, stable on egasidase beta, and then they randomized 2-to-1, where 2 patients are getting peg-unigalsidase alpha compared to 1 patient getting egasidase beta. And the endpoint was eGFR slope. I know this audience is familiar with eGFR slopes. But there was eGFR slope over 2 years. And if you can tell them apart on the top right, you're better than I am, because the eGFR slope was basically all over the place. It was the same in the both the arms. So these 2 trials were crucial to getting peg-unigalsidase alpha approved. Now, one little caveat I want to mention is there's another trial called the BRIGHT study, which I didn't put in here, but the BRIGHT study is a dose of observational study with peg-unigalsidase alpha with 2 milligram per kilogram dose, so double the dose, but dosing every 4 weeks. That observational study looked good, but it's observational, and so it hasn't led to a label change in the US. It did lead to a label change in Europe. So at observational study, you take it with a grain of salt, but that's the best data we have with peg-unigalsidase alpha. All right, third US approved drug, migalastat, Galafold. Now, put it simply, what if you have a variant that is a stop codon and you have 0 enzyme? Then you need the enzyme replacement. But what if you have a variant that is a misfolded enzymes that instead of going to the lysosome gets broken down? Then the chaperone might work. So chaperone literally is something that binds to an enzyme, takes it to the lysosome, and detaches there. And there, because of the higher concentrations of its natural substrate, GL3, it's able to detach. Chaperone therapy works only for certain mutations. You have to have a mutation that is amenable to this therapy. And so there's a list of quote-unquote amenable mutations that you can use chaperone therapy for. The clinical trials that led to migalastat approval, first, 67 naive Fabry patients that were randomized 1-on-1 to migalastat versus placebo. And on the right, you see, again, a rapid drop in GL3 in the intervention arm compared to the placebo arm. during the open label extension, everybody's GL3 normalizes. The second part is looking at GL3 buildup in kidney interstitial capillary cells. So they were able to show that migalastat reduces the amount of GL3 in kidney interstitial capillary cells on kidney biopsies. So again, a different way of quantifying response. So now I've told you about 3 medicines, right? We talked about, if I'm talking brand names, it's Fabrazyme, Elfabrio, and Galafold, which is the chaperone therapy. How do you decide between them? This is what I go through when I'm talking to the patient. First is the mutation. Is it an amenable mutation or not? Because if it's not, then migalastat's out. Age at initiation. If your patient's younger than 18 or not. If they're younger than 18, then you only have Fabrazyme as an approved product. Renal function, because EGFR less than 30 or not, because again, migalastat is approved only for EGFR greater than 30. It's being tested for GFR below 30, but not yet approved for that. Patient preference, IV versus oral. Oh, big thing I didn't tell you. Migalastat's oral. The other 2 are IV. Yeah, little detail. But it makes a big difference to the patient whether it's oral or IV. And lastly, insurance coverage and cost. And honestly, that's what ends up determining what the patients end up getting most of the time, because a lot of times insurance will approve one product or the other product, and you have to try to work with them and figure out that this may not be the right product. Dr. Kalish touched on monitoring on patients with Fabry disease. This is my version of that slide. You check biomarkers, lyso-Gb3, GL3, or Gb3, they're interchangeable, and urine lyso-Gb3 every 3 to 6 months. You check antibody titers every 3 to 6 months, at least at the start, and then once they are stable, maybe annually. And then you check, well, I'm a nephrologist, so I'm going to check urine albumin creatinine ratio every 3 to 6 months, at least at the start, and then till they stabilize. From a cardiac standpoint, they need an EKG annually at least, echo annually, cardiac MRI at diagnosis and every 3 to 5 years, a 24-hour Holter every 2 to 3 years. Now that is being replaced by a loop recorder a lot of times if the patients, especially if they're symptomatic. And lastly, an MRI brain at diagnosis and then every 3 to 5 years. What's wrong with the picture on the right? Something wrong there? Yeah, I don't think this works. Do some monitoring, but not really something that's useful. It's very important to have a multidisciplinary team. As you've seen, Fabry affects the kidney, heart, brain, psychosocial issues. It's challenging to work outside. If you're by yourself, you're not going to make this work because it takes a lot of time and effort. So you have to have a cardiologist who understands Fabry disease, who will look at and see that a short PR interval or a bradycardia in a 20-year-old is something that they're going to pay attention to and not blow it off. Because that's what they would do on a normal healthy person. A 20-year-old with short PR or bradycardia, they may be like, oh, this is nothing. You're fine. You're not symptomatic. But in a patient with Fabry, I want them to evaluate that. So you need somebody who understands Fabry in cardiology, in neurology, because they have white matter lesions on the brain MRI, in addition to early strokes, sometimes pain management to help their neuropathic pain, and then genetics to help understand some of the mutations and variants that I really don't understand. So, all right, now I'm going to move quickly into investigational therapies. Fabry has a lot of interest from industry, and so there are a lot of things to talk about. I have only picked 4 to talk about here, but we can, if you guys have any questions, come up afterwards. We'll talk more about any of them. The first one I'm mentioning here is venglustat. So venglustat falls under the substrate reduction therapy bucket. Substrate reduction therapy works upstream and does not stops production of GL3. And so instead of having to give the enzyme to replace and break down GL3, it just works upstream and stops production of GL3. So it's a completely different approach. It is, venglustat is in 2 phase 3 trials right now. They're called Peridot and Carrot. Peridot is a randomized double-blind placebo-controlled trial that's looking at patient-reported outcomes as the endpoint. So abdominal pain or GI pain and neuropathic pain is the endpoint. Carrot is a cardiac study, and it's a head-to-head from like standard of care against venglustat. So the patients are getting either Fabrazyme or Fabry or migalastat, depending on what they're on, and it's head-to-head against venglustat. And the outcome, primary endpoint is looking at cardiac MRI changes over 2 years. So we should have results somewhere around maybe summer this year from the venglustat clinical trials come out. The next one I'm going to touch base is lucerastat. Lucerastat is also a substrate reduction therapy. So it works similarly, stops production of GL3. The largest trial was the modified trial, and the modified trial actually had neuropathic pain as an endpoint, and it failed to meet that endpoint. But interestingly, they noticed that the patients that were getting lucerastat over 18 months had stabilization of eGFR, so they're pursuing a kidney-specific study looking at lucerastat outcomes. So stay tuned for that. And then I'm moving on to gene therapy. Both the gene therapy candidates that I picked to talk about are adeno-associated virus vectors. So Sangamo, the product is ST920, and Sangamo Therapeutics is the name of the company that's making this gene therapy. It's an adeno-associated virus 2/6, and the largest trial is called the STAR study. And the basic concept is you take the adeno-associated virus and you modify the virus so that the GLA gene is included in it, and then you give the patient a giant infusion of 1 billion copies of that virus. It's not 1 billion, it's actually more, but something like that. And the virus goes and infects mostly the liver, but everywhere. And in that process, that GLA gene is integrated into the host cell, and the patients start making alpha-gal. So some of these patients were in the trial were able to actually get off their enzyme replacement therapy because they had enough alpha-gal. And so it is a promising therapy that is coming down the pipeline. And the next one I'm going to talk about is AMT-191. And the company is Unicure, and it is an adeno-associated virus 5. It is also a liver-directed gene therapy, but this same vector has been used for hemophilia B with success. So the basic concept is still very similar. And again, in 11 patients, they had many patients, and some of them actually had 300-fold normal alpha-gal levels. So some of the patients were able to, again, discontinue their enzyme replacement therapy after getting this. The only safety signal that was noted was liver enzyme elevations in some patients, and the high-dose arm of the therapy arm was actually stopped because of that, but the medium and low-dose arms still continue. They showed biomarker stability as well, so it's again a promising therapy. You'll hear more about it next time. So going back to my overview slide, we talked about the Fabry-specific therapies on the left, and then quickly touching on the supportive therapies. Now, from a patient standpoint, these supportive therapies are also quite important. From a CKD management standpoint in Fabry patients, RASI is the first line for albuminuria reduction, and then SGLT2 inhibitors as well. There's actually data for using SGLT2 inhibitors in Fabry as well. So all of my patients are either on ACE or ARBs and maximized, and then added SGLT2 inhibitor. And then if the CKD progresses, then of course dialysis and transplant. From a hypertension standpoint, I tend to pick ACE or ARBs first, and then if they have evidence of heart disease, then beta blockers definitely help. From a cardiology standpoint, remember these patients get LVH, HFpEF, and then eventually systolic HFrEF. cardiomyopathies. So guideline-directed medical therapies, with ACEs or ARBs, beta blockers, spironolactone or mineralocorticoid receptor antagonists, and SGLT2 inhibitors are recommended. And these patients frequently get arrhythmias, and so many of them will end up needing an ICD placement later in life if they haven't been getting their infusions or haven't been treated earlier in life. The neuropathic pain, you can use a variety of things. Some patients respond to gabapentin, pregabalin. The tricyclic antidepressants work well for them, but it's more similar approach to neuropathic pain as anywhere else. Stroke prevention in patients, remember Fabry patients also, especially classic patients, have much higher risk for TIAs and strokes. And so prophylactic aspirin or clopidogrel in classic patients, but even in late onset patients, if they have evidence of strokes on an MRI, then secondary prophylaxis is quite important. Many Fabry patients have GI disease that gets called IBS. They'll have episodes of abdominal pain with diarrhea or constipation. It's treated like IBS, and so fiber supplements, antispasmodics, TCAs, and SSRIs work quite well as well. And anxiety and depression management also ends up being quite important in these patients because of their such symptomatic burden. They usually have a hard time coping with things. With that, I'm going to stop and save some time for questions.
Matt Langtree from McMaster in Canada. Great presentations. I'd like to underline the importance of SGLT2 as well. That shouldn't just be an afterthought. I think that's really important. I wondered if you had any experience in, especially, so almost ubiquitously, my patients have obesity as well, which raises the question of GLP-1, but can exacerbate the GI symptoms that you brought up. And so I've been kind of nervous about using them. Do you have any experiences with that?
So with all the data that GLP-1s have in CKD, I have started using them. So let me back up. So the GI disease that some of these patients have is constipation predominant in some patients and diarrhea predominant in others. So the ones that have constipation predominant are the ones that we're worried about with GLP-1s. Are we going to have more complaints and stuff? I have not seen anecdotally in my practice that being any different on GLP-1s. That's true. Yeah.
I would also add that, some of the patients actually have difficulty gaining and maintaining weight with Fabry disease because of the early satiety and the diarrhea. So my patient population is not, I don't think that my patient population, that obesity is any more prevalent than it is in the general population.
And I'm from Texas, so everybody has obesity in my clinic. And so,
right. Right. It's interesting. I don't think it's in the literature, but it'd be interesting to look at. Like I said, I've seen about 100 and some unique patients at our clinic. So.
Yeah, there is literature for SGLT2 inhibitors in Fabry-specific patients, like patients with CKD and Fabry, but there's nothing with GLP-1s. But as you mentioned, more and more nephrologists are adding that because of their CKD benefit and cardiovascular benefits in CKD. Any other questions? All right. Thank you, guys. Thank you for coming.